So
a
I'm
little.
here with Dr. Valerie Masuda. My name is Peg Peters. I'm really excited to have you chatting with us, Valerie. You are doing a really cool project here in Canada. And so we're going to kind of take a couple minutes and unpack what this incredible research opportunity is. So as I set the table for this conversation, Valerie, you have been working in palliative care as a physician. You are really seeing that there's a lot of end of life distress in the
Mhm.
people that you are navigating. And in Canada right now, the only thing we've got really to kind of navigate that and to work with that is like MAID, medical assistance in dying, which is
Mhm.
a thing that a lot of people are saying, I don't want to sit in the fear and anxiety that I'm feeling at the end of my life. I just want a physician to help me exit well. And so this is the world that you've been working in, and you are now seeing that there's some amazing research coming out with psilocybin mushrooms, and you have a clinical trial that you've been granted access with Health Canada to do end of life distress therapy with a cohort of people in palliative care. And that
Mhm.
as a physician, you want to take them through the process of having a psilocybin experience to deal with their end of life anxiety. And you want to do a clinical study on this.
Mhm.
Valerie, take us into this story. How did this come about, and why are you so passionate about helping these kinds of people?
Yeah, so thanks, Peg, for the opportunity first to discuss this and really educate people about the topic. Um, I've been working with psilocybin and psychedelics probably for a year and a half, or actually close to 2.5 years, actually. Um, so I had a patient who had extreme existential distress, and she could not actually even be present for her friends and family. She had pain that was intractable, and we tried everything to manage her pain and distress. And she went to tertiary palliative care units, and she was a young woman. They felt we can't do anything with her. We even tried, these special procedures where you're actually doing epidural, putting a catheter in the spinal cord to try to relieve pain. So she had everything, and we could not manage. And she went back home, and her whole family was suffering around her. And I ran into Bruce Tobin, who founded TheraSil, and this was just a chance meeting. And I had heard about psychedelic therapies, but I really thought it was only in the research area and that we really had no access to it. But he informed me that we could get a Section 56 exemption for this patient and provide her with this. And that was under the minister, Patty Hadju. And within 24 hours, we actually had her exemption. We treated her 48 hours later, and it was transformative. For me, I thought, oh my God, we have to have this treatment. It's so essential in alleviating suffering in palliative care. This woman, her pain was managed. We rapidly dialed back her pain medications, so she was on a fraction of what she was on before. She was able to be present for her family. She called in her friends and had actually a big party before she died. And that was a 180-degree shift. Um, since that time, I was trying to offer psychedelic assisted therapy with psilocybin to a number of patients just with underground therapists during this Section 56 kind of milieu. And I wasn't really appreciating sort of this follow up or really good integration. And I found that if patients were not well integrated, they didn't really have great success. So I ran into some people from Roots to Thrive, and I said, hey, can I maybe bring psilocybin for my terminally ill patients who are really struggling with this kind of model? And they said, well, I think you need to go through this as a participant first to really understand what does it mean to be held in a group, to have, they were using ketamine at the time, to be experience a psychedelic experience in a group and to be integrated in the group. So I did go through the Roots to Thrive therapy program, and I was transformed. I thought this is the only way that we are really going to heal people, um, and have come to this understanding that it's not about the mushroom, it's about the program. And when we see these clinical trials where you have the very early ones with Griffiths and Roland Griffiths and using Bill Richards. And I had seen some videos of how they actually did integration and how they sat with the people. And it was unbelievable how artistic they are with holding space, with integration. And then we see more and more clinical studies just not coming out with those same awesome findings. And I'm kind of understanding it's not about the psilocybin, it's about how people are held, how they're integrated, how we use the opportunity for that neuroplasticity to form those new behaviors, those new thought patterns, right? So this is my appreciation. So using this group model, seeing how important it is for my patients who are struggling with understanding why they're dying. Why is my body, it's starting to change? Why can't I go chop wood anymore? Why can't I be the provider in my family anymore? Who am I when all those layers are stripped away? And then in this group, being able to discover who I am and being seen by people that are also struggling with the same questions and seeing them for who they are and having the psychedelic or psilocybin sort of catalyze that. And this is where the medicine is, and this is where the healing is. So last year, we had brought through, probably I treated about 13 patients with psilocybin under this Section 56 exemption. 9 of those were in the group therapy, and really appreciating how connected these people were. They had never really talked to other cancer patients in an authentic way, and bringing them together was magic. That cohort said, we really want to talk about our cancer and death and dying. So our second cohort came under the special access program, and we brought another 7 patients through there. It worked very well. My third cohort, through the special access program, Health Canada said, hold on, you are treating too many patients and you need to move to a clinical trial. So yes, we understand that all these patients qualify for treatment. Yes, we understand they're suffering. Yes, we understand that it's an emergency therapy, but hey, we're not going to give you any SAP access. So we did work with Health Canada trying to get this clinical trial up and started. It was obvious that we could not get this trial started before we could treat these patients. So they did grant us our last special access program, last access through the special access program to psilocybin, and we treated those patients in September. But now we really have to move forward with this clinical trial.
So the clinical trial is an opportunity to demonstrate the efficacy of something you already know works. You already know that this is going to alleviate the suffering. What really amazed me and what you were talking about, Valerie, was the connection between our existential crisis that people feel and their physical experience of pain and suffering.
Mm-hmm.
That was like when you talked about that just now, I'm like, what? I know that it can dial down the existential fears we have so that we know that we're good inside, we're not have to wake up. But I didn't realize that is also connected to the pain that I feel in my own physical body. And you're telling me as this happens, going through these kinds of experiences, people's pain drops down, and you're saying, I don't need as many pain management. I don't need to dope them up as much. They're actually not asking for that anymore. That's amazing to me.
Yeah, and we've also seen people who are self-medicating through substances, alcohol or opioids or whatnot, and they are that use of self-soothing also has gone down. So, for cancer patients, they have real cancer pain, like they have real pain, but can you imagine every single pain? You're wondering, is this it? Am I dying now? So the meaning of the pain is different for somebody with cancer. And this is what sort of informs that, the snowball of distress.
Mm. Wow, I love that framing, and I think to me this is an opportunity in Canada for us to do something really unique in the world. Canada has, this is the country that first understood the importance of hospice care. They understood the importance of the palliative process. Canadians have been on the forefront of developing models of care for death and dying on our planet. This is the
Mhm.
thing that we've been known for as people. Here you are, a palliative physician who sits at bedsides and helps people die well with dignity. And you're saying, all I want is another tool. That's all
Mhm.
I'm asking for. You've given me, Canada, Health Canada, you've given me the tool of medical assistance in dying to relieve the people. You have that tool. All you're asking for as a physician is, can you give me the legal right to also have this tool in my belt when I'm working with death and dying? And I
Mhm.
think that is a very legitimate ask. You've been in Parliament 2 weeks ago. You sat there and with Elizabeth May and a few others, and you asked the Joint Committee on MAID, Medical Assistance in Dying, you asked them to put a Section 9 provision in. Can you explain what that is and why that's so important?
Yeah, so I'm going to just backtrack a little bit about medical assistance design for terminally ill patients. And yes, there are people who feel this is my experience of dying that I want, and that this is what I understand as a good dying experience, and I want to leave that legacy for my family. That's fine. There are some people that really struggle with physical symptoms, either shortness of breath or pain related to their cancer, and they say, I know I'm just going to get worse, and I'm okay with dying. Like they're kind of they're not they don't have that existential suffering, and they're very pragmatic kind of decisions based on where they are in their trajectory, um, and those people usually are quite close to their end of life. And then we have a cohort of patients who very early in their diagnosis just cannot stop thinking about their cancer. They cannot stop thinking about dying, what it's going to look like, how it's going to happen. And it basically clouds every single thought that they have 100% of the day. And many, you say, well, cancer patients that are dying, of course they're going to be distressed, but that's not actually the experience. Usually it's about 5 or 10% that really have that severe kind of suffering. And back in the day, we used to actually put them into a deep sleep they on their request, so they would no longer feel that existential suffering. When MAID was made legal in 2016, some of those people are accessing because they just find that even though dying is something they cannot fathom, living is something they can no longer do because they suffer so much. Every single thought that they have is related to death and dying, and losing the understanding of who they are within that.
Mm.
So this is where we need this tool for people who are dying. However, MAID was supposed to next month become legal for people with mental illness. So people with, what we call treatment-resistant depression, or other mental illnesses could access actually lethal injection, um, to alleviate their suffering. And for me, I think that's a huge, huge problem. I feel that, even my own practice, I have witnessed patients being pressured by friends or family, not maliciously, but out of a sense of, oh, I would never want to go through that myself. I am suffering because I perceive your suffering. You should have MAID because I would alleviate my suffering because I think you're suffering. Um, and I've seen healthcare providers, really from a space that's not malicious. It's like, you know what? This is huge. I would never want to go through this myself. Have you considered medical assistance in dying? And sort of promoting that as the most viable option. And I have had people say to me that they feel actually pressured by doctors to have MAID. So if you can imagine somebody who's in emerge for the 10th time, somebody who, because they've had depression, no longer is working, they are financially struggling, that they have lost those key relationships and they're feeling isolated, they may be abusing substances to self-soothe. Can you imagine that they're not going to be encouraged? And can you imagine in that vulnerable space where you really are suffering that you'd want it out? And what does it mean intractable? We know from people who actually were witnesses for the Joint Committee on MAID, they said, it, 20 years, if I had been offered euthanasia, I sure would have taken a lethal injection, but now I'm good. So what does it mean when we say intractable? So, I really worry that part of the lack of accessing these social determinants of health are really informing that suffering too. So when we start euthanizing or giving people lethal injections because they cannot access the social determinants of health, what's that called? So I think we're on a very, very, very
Mm.
knife edge,
Yeah, I mean,
and so
that's it feels like the word genocide comes up. I was like,
yeah,
we are eliminating a class of people that we are uncomfortable with as a society,
exactly. So
right?
we are
Like this is about
offering
us.
us.
Remember, this is about us alleviating. I don't like to see you suffering. So just can you just go away? And can you just take this pill and oh my goodness, the way you said that, it just hit me about what this opens up when we open this up to intractable depression, a
Mhm.
treatment resistant depression. A 25-year-old, a 21-year-old can say, I've been depressed for a year, I don't want to get out of bed, my life sucks, I just want to end it. And you could say, this is not your reality yet. Like this is
Mhm.
one version of it. What if I could give you an experience that gave you a global understanding of who you are, a more holistic impression than just this narrow depression that you're facing right now? Psilocybin can do that. This is amazing.
Exactly.
Yes.
And we know psilocybin is safe. It's certainly safer. No one's died of psilocybin, but everybody dies from a lethal injection. So comparison, psilocybin is very safe. The other thing is that this is potential for healing, and I think people have to understand that it's not just about taking the drug.
Right.
It's about taking this medicine as that WD-40 to help loosen the bolt for the overall program of
Mm.
support. So this is, the proper setting, the proper integration. So how do we support that
Hmm.
in the context of using psychedelics for mental illness? And
Yeah.
and for us, looking at this group therapy program, this is the first clinical study which uses a group therapy program before, during the administration of the medicine, and afterwards.
Yeah.
If this group therapy program is effective and safe, this is the way we really leverage the
Mhm.
cost
Yeah.
too.
Yeah.
And people then heal in community. Not only do they heal in community, but we've seen them kind of continue those connections of community even after the program, and we've sort of given them the tools to be able to do that. But this is where the impact is.
Mm.
I've seen people in our own programs, if they get treated and they're not showing up for
Yeah.
the preparatory sessions, if they're not doing the work of, I need to look inside myself and work at it, then when they do have that opportunity of neuroplasticity and they're feeling good, and now we can start to layer on new
Mhm.
thought patterns, new behaviors. If they don't show up for integration, then the effects are not durable, right?
Yeah.
They feel good for a couple of weeks, they go back to their ordinary thought patterns.
Yeah.
So it's so important to realize that this is a program or a procedure.
Yeah.
When you look at a lot of the randomized double-blind clinical trials, the the biggest thing is, oh, you can't double blind a psychedelic. Like everybody knows when they
Yeah.
take a psychedelic, it's like, of
Yeah.
course, it's you can't run a randomized double blind clinical trial on a shoulder joint replacement either. It's
Hmm.
a procedure. You either do it and see how the people benefit, or you don't do it and see how the people benefit.
Mhm.
So all this, the
Mhm.
language of clinical trials does not really make sense in
Mhm.
the psychedelic space. But
Yeah.
we are hoping with this clinical trial to demonstrate that 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 people can heal in group, and that it's actually much more affordable, effective, and that it could be funded through the public healthcare system.
I think that's such a beautiful way to kind of bring this bow back is, What you were doing on Parliament Hill was talking to a joint group on the MAID, legislation, and saying, please include that physicians need access to psilocybin as an option that they can offer prior to offering MAID. That's all you're asking right now. And
Mhm.
Parliament has to make a decision on that in the next 8 to 10 months to
Mhm.
ratify that section 9 of the MAID legislation.
Mhm.
And I hope that your clinical trial will help give us the data that Health Canada needs to know this is a safe, effective treatment that can help people not just kind of ease their end of life anxiety, but reduce pain and suffering for Canadians. And I think where you ended your comment there before is, let's do this in a way that's in a group model and make it affordable and accessible for Canadians. And this should be covered under
Mhm.
our healthcare. Canadian healthcare should cover this treatment. This should not only be accessible for the rich people that get
Mhm.
to access private, experiences like this. This should be for everyone, regardless of your financial status in Canada. And that can only happen if we prove this out in a clinical trial. That
Mhm.
is what we need. I wish it wasn't, but that is the cachet we need in Canada. We need a clinical trial to prove this, and then we can open up the doors to be able to allow physicians like you to use this kind of group model to help people.
Mhm.
And I want to just kind of wrap up this little story here. If people want to get involved, and this is a part of this is a kind of a public service announcement for people, is that there is a clinical trial happening. This is important work. And if they want to support this, it's going to be costing about $24,000 to bring a cohort of about 8 people through this 12-week protocol and this experience with doctors and therapists and the whole kind of program. It's about $3,000 per person.
Mhm.
This is expensive, but it's nothing compared to what normal clinical trials are. So we're
Mhm.
asking, if you're out there and you're intrigued at helping move this needle forward with healthcare in Canada, you want to support Dr. Valerie Masuda in her clinical trial, Vancouver Island University is helping you do this clinical research, and people can donate and get a personal tax receipt from Vancouver Island University for this clinical trial. And so we are
Correct.
hoping to get your clinical trial launched here in June of this year. To start the first cohort, and I'm really excited. And so this little video is designed to help inform people and excite them to say, we have an opportunity here to move the needle in Canada. Let's help Valerie make history here in the world by doing the first clinical trial using group therapy to help end-of-life patients. How does that
Yes.
sound, Valerie?
That sounds awesome. Thanks for wrapping that up so
Yeah.
so concisely.
Okay, well, thanks so much. And we wish you all the luck on this trial. And I'm going to do everything I can to support you and get people to donate to this clinical trial so we can move this thing forward.
Thank you, Peg. I really appreciate it.
Awesome.